Hi everybody, good to see so many of you here today. I'm Nimisha from the Clear Communications team, and I'll be co-hosting today's webinar, where we'll discuss our Clear Elective Recovery project at James Paget University Hospital's NHS Foundation Trust. This session is part of our Clear Impact webinar series, which brings together those involved in delivering our latest transformation projects to share their learning, reflections and impact of their work. A reminder that today's session is being recorded, so we can share it afterwards on our website and across our networks and channels. So today's webinar centres on our Clear project at James Paget, which looked at improving their elective trauma and orthopaedic services. The project, along with two others at different trusts, was commissioned by NHS England to support delivery of the NHS Elective Recovery Plan, which aims to increase capacity and cut waiting lists for elective care. So we'll just have a quick look at who we will be joined by today. So we have James Kelly, who is Managing Consultant from the National Clear Programme, who led the project at James Paget. We also have Lisa Newball, Senior Clinical Consultant from the National Clear Programme, Christiana Silva, Senior Clinical Consultant again from the National Clear Programme, and we're very lucky to have Mr. Sunil Garg, Consultant Orthopaedic Surgeon from James Paget, who will talk to James Kelly about to share his reflections on leading this project and aspirations for the future. We'll just have a quick look at the agenda before we get things started. So James Kelly will kick off proceedings by giving a brief overview of the National Clear Programme. He will then outline the Clear Elective Recovery Programme, and will hand over to Christiana and Lisa from the National Clear team, who will give a brief overview of the other Clear Elective Recovery projects as part of this programme, one at East Lancashire Hospital's NHS Trust and another one at Kettering General Hospital. They will then hand back to James, who will present the main part of the webinar, which will be the findings, recommendations and projected impacts from the James Paget project. James will then host a couple of discussions with our speakers for their reflections on leading this elective recovery work at James Paget and at the other two sites. We will then have a Q&A, which will be your opportunity to ask questions to our speakers, either through the Teams chat function or verbally by pressing the hand up icon, and we'll come to you for your question. So that's everything from me at the moment. I'll now hand over to James for the core part of the webinar. Thank you, James.
Thanks very much, Nimisha. So I'm going to start by talking about the National Clear Programme and giving a bit of background to it. So if I could have the next slide, please. The Clear Programme was developed in partnership with Health Education England, now merged with NHS England. And it's worth pointing out some of the differences between the Clear Programme and other transformation programmes in an age when it does feel like there's quite a lot of transformation projects competing for everyone's precious time. So the Clear Programme is sponsored by NHS England, which means that the funding for it comes from NHS England, not from the sites on which we work. And because we tend to work across sites, then we're looking for solutions from those sites that can be rolled out more widely. And that really helps to embed impact assessments and a impact plan and implementation plan in the planning of the programs themselves. The overarching principle is that these transformations empower the frontline clinicians to design innovative new models of care and new models of workforce that can work on their sites and work across other sites as well. If I could have the next slide, please. The methodology we use is a four-step process that begins with really rich clinical engagement, in which we talk to members of the frontline clinician and support teams to find out what the key challenges are that are being experienced on the sites. Then we combine that with big data in a data interrogation phase and triangulate the qualitative data that we've collected from the clinical engagement with the quantitative data that we get from the individual site data sets. We then move into an innovation phase where we look at potential new models of care and new models of workforce that can meet the challenges that have been identified in clinical engagement and quantified in data interrogation. And then we present them as recommendations to the host trusts along with an implementation plan. Could I have the next slide, please? So the principle is that we combine this really rich qualitative data from clinical engagement with big data analysis to improve patient experience and care by building a community of practice within the NHS that's driven by educational initiatives. At the moment, the team is a large one, comprising more than 70 staff. A lot of us are NHS clinicians working part-time for the CLEAR programme and part-time for the NHS. And we also have education specialists and data analyst specialists to inform the work that we do. Can I have the next slide, please? The aims are to maintain an improvement that is clinically led by the trusts at which we're working, that embeds new skills and new ways of working, and that remains owned by the trusts in which we work to really prompt the implementation and successful delivery of the programme. Could I have the next slide, please? CLEAR has been going for a number of years now. It rapidly upscaled during the COVID-19 pandemic and now has been delivered more than 60 times across England and across a real broad range of specialties, from critical care to ophthalmology and this one, elective recovery. Can I have the next slide, please? So let's talk a bit about the elective recovery programme itself. So this has been going on since about middle of 2023 and has involved on sites 3 different projects that are linked together. The James Paget University Hospitals project, which we're going to talk about in a bit more detail, and the Kettering and East Lancashire Hospitals projects, which we're going to touch on briefly and can answer some questions about, but isn't the main focus of the presentation today. NHS England commissioned the programme to look for solutions to reducing the huge waiting list that had built up and were exacerbated by the COVID-19 pandemic, particularly around trauma and orthopaedics. So the focus of the project is on adult elective trauma and orthopaedic care. It intends to develop practical, financially viable new models of care to solve some of the waiting list problems and increase patient flow. Could I have the next slide, please? So I'm just going to pass over to Christiana to talk about East Lancashire and then Lisa to talk about Kettering.
Thank you, James. Can we move on to the next slide, please? Hello, everybody. My name is Christiana. I'm one of the senior clinical consultants working for the CLEAR programme. I'm just going to guide you briefly through what we've done with ELHT Elective Recovery Project. As part of the CLEAR, we focused on the elective and trauma orthopaedic pathways with special emphasis on how structures and processes could be optimized to allow a higher efficiency of the service. During the clinical engagement phase, we have interviewed many professionals on a one-to-one interviews and group sessions, and we came up with 4 key themes that reflected what we understood from what we were being told. So there were variability in service consistency, where there were inconsistent service planning and delivery and a lack of standardized operating model and expectations across the team. We have identified system and processes where challenging pre-op planning and scheduling processes alongside with underutilized intra-op theatre resources and variable post-op processes. We have identified the 3rd key theme as being the trauma impact on elective capacity because of the high demand of trauma. specialist skills and provision of clinics in theatre lists. There was also an increased complexity of patients and pathologies complicating recovery. And fourth, was the workforce recruitment and retention with high demand, with reducing capacity, resulting on workforce attrition. Looking at the data analysis that we then underwent from the data set we were provided, we could match the data we were looking at with the 4 themes identified. And on the first theme, we could see there was a high variable theatre use with variable productivity throughout the week, with impact on pre-op and post-op patient flow. On the second key theme, systems and processes, we have seen that there were roughly 3,000 cancellations in a period of 4 years, with 85% of these being elective cancellations occurring on the day or the day before surgery, and the proportion of same-day cancellations increasing over time. When looking at trauma impact on elective activity, we have seen that there was a rise in trauma urgent outpatient referral, and there were trauma outpatient attendances not matching increased trauma demands. The trauma patients were also becoming older and more complex. There were frail trauma log lengths of stay patients are increasing in proportion of work, and already accounting for 47 days per year. And lastly, trauma elective sessions were remaining the same. In terms of the workforce, we have found that there was a degree of workforce attrition, most notable among senior medical workforce, and there was also loss of theatre productivity due to the lack of workforce, likely to account for roughly 400 cases over 4 years. So having that in mind, we have moved on to the innovation and recommendations and identify key challenges and opportunities, and we have suggested that there should be a consistent delivery of services. There should be a pre-op booking, anesthetic assessment, and surgical validation process to reduce cancellations, and this would equal roughly 400 cases a year. We have suggested that the intra-op theatre utilization would be maintained consistently throughout the week, and post-op services would benefit with these gaining a 300 bed days per year on elective, and trauma saving roughly 1,600 beds days a year. Next slide, please. So this is just to give you an overall vision of what we've done during clinical engagement and data interrogation. So during the clinical engagement phase, we have spoken with 60 members of staff with inductive and semi-structured interviews on one-to-one and group sessions across booking, pre-op assessment, theatres, recovery, and the wards. And we also attended clinical governance and audit meetings. The data interrogation phase was done based on the data obtained from ELHT, theatre and EPR and outpatient systems, and national data. Theatres and inpatients was a roughly 50,000 case records over 11,000 sessions, including any patients with trauma and orthopaedic wards between the 1st Jan of 2018 and June 2023. There were over 15 variables per record reviewed alongside clinical teams, and the outpatient log was roughly 150,000 referrals associated with 400,000 appointments from 1st of April 2018 and May 2023. Next slide, please. I will hand over now to Lisa to talk about catering.
Thanks, Christiana. So my name's Lisa. I'm one of the senior clinical consultants and was leading over at the catering site, which we are just now in our recommendations phase, just about to publish our final report for the trust. So similar to ELHT and James Paget, we were focusing on elective orthopaedic pathways, particularly looking at their pre-op assessment in view to try and reduce on-the-day cancellations of patients who are not fit for surgery on the day. Looking at the overall efficiency within theatres and theatre utilisation, the Trust really wanted to try and focus on being able to provide more for joint lists within their main theatre suite, and doing that within the current workforce that they currently have. Also looking to reduce length of stay by looking at criteria-led discharge and enhanced recovery pathways, particularly within the frail population who they struggle with in terms of post-op rehabilitation beds. So following our full process, we engaged with more than 40 staff across the entire perioperative pathway, starting right from pre-op assessment and all the way through to recovery, and the ward staff as well. And we came up with 4 key themes. So in terms of workforce, one of the main things that came out of this theme was that there weren't enough staff available to provide lunch cover. So even though they had all-day lists, it meant they had to stop usually for around an hour, hour and a half while staff were relieved for lunch. So that created a real gap in the middle of the day to sort of theatre efficiency and flow. Coming on to processes and pathways, it's very similar to ELHT. Trauma demand is having an impact on elective provision, and quite often having to cancel cases because of trauma demand. With there being quite a short pre-op assessment expiry time, it meant that patients were either having more than one pre-op assessment, or by the time they were due to be listed or have their surgical date, that their pre-op assessment had expired and therefore needed to be done again, which was causing issues. And that due to the increase in the frail population, so post-COVID, ASA2 patients had increased by 25%, and they were finding it challenging being able to plan for post-operative care and rehabilitation for these patients. But not only that these patients were taking longer at each stage of the perioperative journey. In terms of staff training and experience, due to there not being enough staff, there wasn't enough mentors, and orthopaedics is quite a heavy specialty to train and scrub for. So staff were finding it that they didn't necessarily have the support they needed to learn and grow within the specialty, or staff were being pulled elsewhere to cover other areas even if they were experienced in orthopaedics. Not only that, but there was no provision in terms of staff training for anaesthetic courses and upskilling in other areas of the theatre workforce. But I think one of the main issues in this hospital, and it came up time and time again, was that the 2 orthopaedic theatres within the main theatre suite couldn't use their exit doors due to being blocked by equipment and stock, and that caused real issues in terms of patient flow, because it means that they can't bring their next patient round to the anaesthetic room until the previous case is finished and cleaned, because they have to exit via the anaesthetic room. Not only that, but the theatre suite is a 5 to 10 minute walk from the patient admission ward, which can cause real delays in getting patients to theatre, particularly at busy times at the beginning of the day, or at the middle of the day when lists are all getting going. And that caused anywhere from 20 to 40 minutes delay on average per patient. So from the data, at the time of data collection, there was around a 10% what we call felt vacancy rate. So although it looked as though the theatres were fully established, due to long-term sickness, maternity leave, sort of supervisory, because staff had just arrived in the department and needed a period of supernumerary practice, that there were actually what they called felt vacancies within the team, which were causing impact. It was found that more than 15% of elective sessions contained trauma case, and that 15% of patients were attending more than one pre-op assessment appointment. As I sort of alluded to earlier, the increase in the frail population, so over 65s. So there's more than 90% of over 65s with an ASA grade of 2 or higher. So sort of getting into those realms of more complex patients. And they had an average length of stay of 14 days, although having spoken to the site and presented them with the report, they've reported that this is coming down already, which is great. In terms of the estates and resources and that flow through theatres, due to the fact of not being able to use their exit doors, their treatment time utilisation is sitting currently around 77%, where the target should be sitting at around 85%. Next slide, please. So based on all of our clinical engagement and the data that we collected, we came up with some recommendations, and unfortunately we haven't got time to go through them all here, but I think 3 of the main ones from what really came out from the data was that if there was staff recruited solely to focus on break relief, or to fill out those gaps so that that staff could have adequate break relief, would mean that theatre lists wouldn't have to stop, and that time would be put back into the operating list. The cost of 2 staff is around £88,000, and that was modelled to show that they could facilitate. This was 10 theatres, so we didn't do it for the full 20. So even just 10 theatres, you could achieve efficiency savings of over £2 million. So that ECC there is the implementation of an elective care coordinator, with a view that they would pick up the more frail and complex patients at the point of being listed and have them as a working caseload to really navigate and plan for the effective pre-op assessment, making sure they're being seen in the right pre-op assessment clinic first time, and not having to repeat appointments, making sure that they're optimized for the day of surgery to make sure that's reducing the on-the-day cancellations, and really planning then their discharge care to reduce that length of stay. So that would be 2 members of staff to cover the elective caseload across the year, and could achieve savings of over £300,000. We also noted that the hospital doesn't have a surgical admissions lounge, so a dedicated surgical admissions lounge. And we sort of recommended that with the implementation of a surgical admissions lounge co-located to theatres, so that patients could walk to theatres, would really help with the flow and being able to get the patients to theatre much quicker and more efficiently. Not only that, but it would make it much easier for the clinicians, so surgeons and anaesthetists, to be able to see those patients more quicker and efficiently in the morning prior to list starting, and also sort of stagger those assessments over the day so that it didn't take up so much time in the morning when you're trying to get the list started. So implementing that would cost around £150,000. But with the on-time starts and the additional time that you'd get at the beginning of the list, could achieve efficiencies of over £300,000. Obviously, other benefits include, like I was saying, reduction in those on-the-day cancellations, reducing length of stay, improving access to pre-op assessment appointments, but not only that, making it more efficient and streamlined, which would hopefully benefit staff and making them feel more happier to go to work, and that they were doing the job that they were trained to do. And I think that's it for me, so I shall hand over to James.
Thanks very much, Lisa, and thanks also, Christiana. So I'm going to talk very briefly about James Paget, give a bit of background to it, and then talk about our main findings, and then start a question and answer session with Mr. Garg. So we can take some questions about the other sites as well, but let's do it at the end. So could I have the next slide, please? James Paget is a medium-sized multi-disciplinary hospital in Great Yarmouth that serves a diverse and diversifying ageing population. We always start by looking at national data sets to get a sense of where the hospital is positioned, and we could tell immediately that TNO services were excellent and they were regionally leading. It's worth noting that because we're talking about here optimization of processes rather than quality improvement driven by pressing need or any sort of safety concerns, etc. There was a steady trauma demand with growing elective waiting lists, and TNO services were the second largest specialty in the referral to treatment long waiters, so those waiting more than 52 weeks. And so despite the best efforts of staff, there was some impact on the capacity to provide timely operations, and therefore there was an impact on patient care. Can I have the next slide, please? So we then started looking at the quantitative data from the trust and the qualitative data that we collected from staff engagement. We interviewed more than 50 members of staff in a combination of individual interviews, group interviews, focus groups, using inductive semi-structured approaches, and also factoring in some observations of meetings and attendance at clinical governance, theatre forums and steering groups. We compared and contrasted results from that to our quantitative data review of about 12,000 operations over about 5,000 sessions from the 1st of January 2019 to the 27th of March 2023. And that looked at not only elective procedures, but also emergency procedures, so that we could look at the impacts of emergencies on elective work and inpatient and outpatient data. And a particular advantage of the approach we take is the ability to visualize these changes as with these connections between data sets in quite nice visualizations that show us the flow and allow sites to really get more insights than they can previously have into how patients are admitted and then transferred between clinical areas. Could I have the next slide, please? We're going to look in more detail now at the findings and our eventual recommendations. Could I have the next slide, please? So we looked at the main findings in terms of where they were positioned in patient flow, so pre-operative, intraoperative, post-operative mainly, but also including pre-treatment, referral and admission. And we then looked at where they sat in terms of their impact on processes, their impact on workforce, their impact on estates and equipment. Could I have the next slide, please? And we distilled that down into three main themes. One was around the complexity of patients. So 25% of trauma patients were frail. More than half of elective patients had indicators for frailty. So the one we've picked out here is that they were greater than 70 years of age. There was increasing complexity and age that was also increasing duration of care and leading to longer hospital stays. And the top four of the same day patient cancellations was because the patient was considered not fit at the point at which they were sent for. The second major theme was demand and capacity. There was a disconnect, a dissonance between outpatients referrals uptrending and attendance downtrending. There was a growing list of patients waiting more than 52 weeks. The trauma demand was increasing and was having an impact on elective surgery, but primarily by the trauma demand resulting in long stayers on the wards. So the amount of people in trauma and orthopaedic beds was predominantly trauma related. And there was also some issues around week planning. So some long stay surgeries were happening at the end of the week, and there wasn't much opportunity for engaging in physio, etc., over the weekend. And trauma and elective utilisation and efficiency was included in the demand and capacity theme. And then bed capacity and patient flow was our final theme. There was a long length of stay for complex patients. So a quarter of patients were occupying just over 80% of the trauma and orthopaedic bed base. And so that was preventing new elective care admissions coming through. Could I have the next slide, please? So we came up with 3 main recommendations and then a number of quick wins that we'll talk about in a minute. The first was the provision of a 7-day physiotherapy service to start rehabilitation and crucially start facilitating discharge of the proportion of TNO patients who had a length of stay of greater than 2 days. So that smaller cohort was around 3,500 TNO patients, of which 50% had a length of stay of greater than 2 days. And we recommended the recruitment of essentially 2 full-time Band 6 physiotherapists and 4 Band 4 physiotherapists, which would be a cost of 211,000 pounds. And the opportunity that would afford is that you could have a 2-day reduction in length of stay per patient. That was a conclusion driven by literature review and data analysis. That would conservatively save you around 709,000 if you successfully got 50% length of stay reduction. Could I have the next slide, please? The second main recommendation was around elective care coordinators, and this is something that Lisa was mentioning earlier, something that we're recommending on other sites as well. Patient complexity contributed to around 10 cancellations in the 7 days prior to surgery per month, and that was resulting in a not insignificant loss of productivity. So we recommended that elective care coordinators could be employed to identify patients early who are at high risk of cancellation and avoid that. And that would require the recruitment of around 2 Band 7 members of staff. Elective care coordinators have been successfully employed in other sites, and so Band 7 appears to be the optimum banding, and MDT members are included in the recruitment. The cost of that would be 137,000, but the opportunity that this would afford is reducing cancellation rates and crucially also generating education and training opportunities. It would reduce the length of stay by reducing cancellations and could improve interoperative communication around prioritisation and cancellation. So we estimated a conservative saving of 60,000 from reducing cancellations by 50% and conservatively a saving of 48,000 from reducing length of stay by 2 days for 50% of the cohort, making a saving of 108,000. So not cost neutral, but because we were conservative with both estimations of savings, in reality, we would expect it to be essentially cost neutral. Could I have the next slide, please? And then the third was theatre improvement leads. And that was motivated by there being several disparate ongoing projects to improve team coordination and sitting within a quality improvement umbrella in an environment in which senior theatre management was historically somewhat under-recruited. So a theatre improvement lead could revalidate some of the theatre workflow assumptions and estimates that were driving other quality improvement projects at the site. So estimates such as turnaround time for CSS, for cleaning services, essentially, and to pull together these discrete efforts to improve coordination between teams. Also, there would be a strong education element and championing of QI methodologies, and medium-term projects had been identified in engagement that could be already included in that, like diversifying the equipment order list, for example. And for that, you'd need around 2 members of staff at band 7, so that would cost around 137,000. Because there are 28 administrative staffing or timing cancellations per month, the investment in this would potentially increase theatre efficiency, reduce those cancellations, and reduce length of stay, and crucially pull together and provide a focus for efforts at improving team coordination. And there were several other things like team job planning that were going on at the site that would be relevant for that. The roles would generate education and training opportunities also, and inform future quality improvement efforts by questioning some of the assumptions that were perhaps somewhat undermining some of those efforts. If we estimated a 15% reduction in administrative cancellations, then you would have a conservative estimate of savings of 50,400. So on the next slide, let's look at the overall, on the next slide, let's look at some quick wins, which are things that would take little time to implement but could have a significant impact. So greater use of all-day lists, and that was uptrending anyway, and reducing equipment-related delays by packaging loan kits in a different way. Next slide, please. So we've represented here how those recommendations impact on the key challenges. So you'll see that across the 3 main recommendations, there's good coverage of the 3 significant challenges that the site is facing. Could I have the next slide, please? Overall, taken as a complete package, if all of these recommendations were implemented, then we would suggest that this would significantly save money, so around £400,000. The patient experience, crucially, would be better. There'd be a reduction in cancellations, a reduction in length of stay, and staff experience would be better because there'd be improved provision of training and development. There'd be team-led and owned QI processes, and there would be dedicated roles to prompt team coordination. So on the next slide, please, we're going to start by reflecting on what this project has meant for those of us who are involved in it, and to invite Mr. Garg to contribute to that as well. And also Lisa and Christiana, we're going to talk about what impact taking part in this project has had. As a way of leading into that, I wanted to say how much I've enjoyed working at James Paget. It's an excellently performing site that has several points of great practice that I think can be communicated across other sites. And in engagement, I've found everyone that I spoke to was very motivated to improve patient care wherever they could, and had some great ideas for how to do that. Maybe I could invite Christiana and Lisa to reflect on involvement at East Lancs and Kettering as well.
Thanks, James. Yes, definitely. I would say the same about East Lancs. Really great team effort, really good practice, people really motivated to give the best care they could possibly do to their patients. And I not coming from a theatre's background, I have learned lots, and people also wanted me to be part of that learning process, and were very patient and helpful.
Yeah, I think I would say at the Kettering side, again, staff were actually a bit cautious to begin with because they'd had so many consultancy companies coming in to have a look at their practice and processes. So initially it was very much they had transformation fatigue, shall we call it, and they were very skeptical and wondered, what we would do differently and what we would bring differently. And I think because of my history and my background as an ODP, working in theatres for many years, I quite quickly won them over and built up some really strong relationships, so that by the end of the process they were all really on board and actually quite excited to think that of the potential changes that could be made from the work that we'd done with them. So that was really nice.
Great, thanks very much. Yeah, and that's an interesting point to mention backgrounds as well, because I know, Christiane, you said you're not from a theatres background, but you're from a nursing background. Lisa's from an ADP background. I'm from an anaesthetic background. That's really helped this project move forward, that we've got a multidisciplinary way of working and thinking about these things. I wondered, Mr. Garg, if you had anything that you wanted to reflect on about how it's felt from your point of view engaging with the CLEAR programme.
Hi, James, and the entire team of CLEAR. So first of all, a massive thanks to you for this piece of work, which hopefully will be useful in our elective recovery. I apologize, I'm in theatre, so if you hear any background noises, but I'll be very interested to know what my other sort of colleagues think, clinicians, administrators, or nursing colleagues. I really like the Kettering presentation, and I think there's lots to learn from the Kettering presentation for us as well. And obviously the Paget presentation, I think there was more to do with how we could increase the productivity from the Kettering presentation, because there was a lot of focus on the presentations about how we could sort of save money rather than increasing productivity. I would have more, maybe it was the way it was projected, the number of cases, extra cases, or how could we increase capacity in terms of, because the whole program is about elective recovery. And I think it does tie in with the savings in a way, but it'll be more useful if we could demonstrate how clearly with implementation of what you are suggesting, we could increase capacity in terms of productivity and number of cases per year. So that would be quite useful. But I'm just interested to just maybe know from you a little bit more about the 3 recommendations you've made. And the physiotherapy recommendation is very much welcome, and you know, that must be hopefully that we will work on that. I think we've got a bit of money from the orthopaedic elective hub, and we are in the process of recruiting that anyway. I can't see if Melissa and Renee are on the call, but if they are, they will probably talk about that. The elective coordinator is a very interesting sort of recommendation. I think we always have had trauma coordinators who make a massive difference to our trauma, and it always stuck to me that why don't we have an elective coordinator? I'm glad you suggested that. The only thing is I can't just put them into my head clearly that what their roles would be like, how would they coordinate, because I think an elective coordinator could help loads in terms of you know, tying all the dots together. But I haven't had any experience of elective coordinator in any of my previous hospitals. But I mean, admittedly, I've been in this hospital for 14 years now, so you know, I'm a veteran and a dinosaur now. But from the previous hospitals, so it'll be a new thing if it gets implemented. And so, and lastly, the theatre sort of another leader. I mean, and we are seeing one of the failings of the NHS has been recruiting more managerial administrative staff, and that has been a major criticism worldwide. And I think personally, I don't have any data to prove or disprove that, but that recommendation again was quite interesting. So yeah, I quite thank the entire staff for, you know, telling us in kind of what we already knew, but you know, in a different way maybe. So once again, thanks very much, and I'll be very keen to hear from other members of our like Mr. Nackler has raised his hand.
Hi, and thank you for your presentation. So I think that interestingly, most of the solutions that you proposed go around employing more staff. have you looked at all at incentivizing the staff we have currently for doing more work? So I do 4 joints in my NHS list, and we finish, well, 5:30, something like that. I do 8 joints elsewhere and finish earlier time or same time. I think the model we need to be looking at incentivizing people to do more work within the available time, and I think that this can work brilliantly if done properly. And just an interesting point is that my operating time, skin to skin time, is exactly the same whether I'm doing 4 or whether I'm doing 8 and finishing at that time. So I don't think it's fair to try to look at different ways to increase the workload within the time I have. So to do 5 or 6 or whatever on the NHS list, without everyone working much harder to get this work done, having a proper incentive and reward for doing it. If we stick by the NHS hourly rate, then there is no incentive at all for anyone to do this additional work and go that extra mile to get it done. Thanks.
Thanks very much. That's a really interesting point around how we pitch our recommendations, and this goes back to Mr. Garg's point as well, because you may have noticed the disparity between how we're pitching at Kettering, for example, and how we pitch at James Paget, and that's partially around how well James Paget is performing with very high theatre efficiency rates already. So an emphasis on increasing patient flow and increasing theatre efficiency wasn't one that we took, because our emphasis was on increasing patient satisfaction and staff satisfaction and saving money. So going back to Mr. Garg's point around these 2 new roles, they have some bearing in what you're saying as well about how to incentivize staff, because one of the big problems we found was, how do you recruit, for example, senior theatre managers in a place where historically it's been under-recruited because it's not seen as particularly attractive? And that's why we've combined it with a recommendation to turn it into a theatre improvement lead, which is a fixed term role that then moves into the senior theatre management role after a fixed term, so that you essentially can give somebody control of the disparate QI programs, give theatre ownership of it, and identify that person and that role as champion. And in the elective care coordinator role, a big part of it again is around staff satisfaction. So we're suggesting 2 people because of the possibility of turning it into an educational program in which one person focuses on frailty and one person focuses on pre-assessment. So frailty is a particular problem at James Paget and could be an area that someone wants to potentially specialise in. Having an elective care coordinator who can look at the inpatient cancellation rate up to 7 days before an operation and reduce some of the potential problems that a frail patient faces, gives the opportunity to reduce that cancellation rate, but also can allow someone to specialise in a particular field and follow a more sort of career development pathway that hasn't previously been possible. So the actual role itself looks quite different to a trauma care coordinator, but I think the impact would be similar. Hopefully that answers.
Well, thanks. That shows how things can improve in general, but I think with that we have to accept that we're doing now the maximum which can be done within these circumstances. That's 4 joints in a day, and we're not looking at making them 5 or 6 or 8 like I do elsewhere. I think if we try to look at options of trying to improve our efficiency as well, and not accept the fact that 4 is the accepted norm across the NHS, but look at it in a way that people are happy doing it and not being forced to do it, and not feeling that they are overworked by doing that without getting anything out of it. I think that will benefit the trust and benefit the massive waiting list that we're having even more.
Absolutely. Thanks very much for your question.
Sorry, James, can I ask you, were you aware of the orthopaedic elective hub we are building?
Yes.
Okay, thanks. Yeah, so we're doing a lot of work around that now, and obviously we our major challenges there are around staff recruitment, especially the anaesthetists, and that seems to be a national issue. But as you said, we are not very attractive in terms of the geography, probably, and that's why we have not been able to recruit any consultant anaesthetist. Well, we have one, but we need several others. So that's another big issue when you try and do extra work, like the weekend work or whatever model you want to follow, and so that's one big stumbling block. But with the new hub, at least we will have a ring-fenced area, which will give us better patient flow there. Our length of stay, if you look within the sort of the ICS, is not bad. At one stage, we were one of the best, to be honest. The theatre productivity, as you already alluded to, is also very good. The staff is motivated. The entire sort of the whole pathway is quite motivated, to be honest. It's just, I think, staff shortages and capacity which we are struggling with. But the newer ways of looking at it, like pre-assessment or saving cancellations, would be a good idea, actually. So how do we? So do you present this to the execs as well, or how do we move from here? What happens next?
We've presented to the executive board.
Okay.
So this is around sort of information giving and gathering, widening out the message, getting questions about it, and then we can talk more about implementations separately.
Okay. Sure, because I think, if I remember, these slides were sent to us sometime back one day, and I did share this with my colleagues. So some of the findings which you mentioned, we were privy to them prior to this meeting. So I think that was a good thing in a way. So thank you for that. So I think we will obviously take these recommendations to our division and then over to the execs and see if because I know that trust is looking massively into this cost improvement program, and I think your findings would be useful. So spend more to save more. That sort of thing. That's the theme.
Thanks very much. Do we have any other questions from anyone else on the call?
Mr. Nene, he's one of our senior consultants.
Yes. Hi. Hello, James and Clear team. Thank you for this very interesting analysis of the issues regarding productivity. I think one of the things which you said, which I thought was very salient, is when you observe that having a few key staff in between can massively increase efficiency. Like, for instance, having maybe one extra ODP to smooth over the process of getting from one patient to the next can make a lot of difference. And I think, as Mr. Garg has said, when these issues are presented to the board, then adequacy of staffing is a very important one, because not only does it improve efficiency, it improves the well-being of those other staff who are in theatre, so that they don't feel overworked. And then in this kind of situation, even the ability to do the additional case, as Mr. Nakla was suggesting, becomes possible.
Great, thanks very much for that observation. Any other questions from anyone in the room? Can I pass back in that case to Nimisha to wrap up the session, and thank everyone for their time.
Thank you everybody for your time and sharing your insights. A really fascinating session, it's always fascinating to hear how the CLEAR methodology is being used to develop recommendations, design recommendations. Really thank you to everybody involved in the project for sharing your insights and learnings. And I look forward to hearing how the T&O services at each of the 3 trusts develop over the next few months. So that's almost it from us. I just wanted to quickly mention the next webinar as part of our Clear Impact webinar series, which will look at women's health. So this is our Clear Women's Health project in Derbyshire, which focused on reducing outpatient follow-up, improving access and cutting waiting times. So that's our Women's Health project in Derbyshire, taking place on the 8th of August from 12 noon till 1. So we really hope you can enjoy that webinar. It will be a very similar format to this one, where we'll share findings, recommendations and projected impact of that project in Derbyshire. More details of that session will be we'll put on our website, and we'll also share it on our social media channels. So please do look out for details of our next webinar on the 8th of August. And just very finally from me, if you would like more details about the CLEAR programme, we have case studies and details about how the CLEAR methodology works. Please do have a look on our website at clearprogramme.org.uk, or please do get in touch with us with your questions, or if you would like a call about how CLEAR can support you in your organisational site, please do get in touch, info@clearprogramme.org.uk. Please do also follow us on Twitter. You've got the handle there, at Clear for Care. So thank you all once again for your time, and I hope you have a great afternoon. Thank you very much.